It's a pleasure to be here. Thank you so much for inviting me, even if it has to be at a distance. And it was really wonderful to meet everyone today in the various groups and nice to meet some of the other people tonight. And I look forward to the Q&A. So I work at Bellevue. It's very similar to Grady, and I have Thursday evening clinic. And one of my Thursday nights, I was just getting ready to leave. You know, you turn the computer off, you lock your file cabinet, you're about to click off the lights when the phone rings. And you always think, gosh, should I answer the phone or not? And I answered the phone, and it was Omar Amadou, one of my patients. And my first thought was, ugh, not again. I'm embarrassed to admit that, but Mr. Amadou is the kind of patient who calls all the time. I'd only known him for a couple of weeks at this point, but I'd probably fielded 50 phone calls from him. He was only 43, but he had a serious cardiomyopathy. And when I first met him, he hauled in this huge stack of medical records from a cardiologist in Pittsburgh, detailing all of his stays in the ICU and his defibrillator and his ICD and his pacemaker, various CHF exacerbations. So when he called, I had still to take him seriously, even though he's always leaving me messages. He always needs something. He needs it right now. He needs a prescription or a form filled out or a prior authorization. Um, so I asked him what's going on, and he couldn't really tell me anything specific. So I grilled him on questions that would suggest arrhythmia or CHF, but he had none of those symptoms. Just he wasn't feeling it. He just kept saying, "Dr. Ofri, I need to see you. I need to see you." So I said, listen, Mr. Amadou, on Fridays, I'm not actually in the clinic. So if you're feeling very sick, please come to our walk-in clinic tomorrow, and one of my colleagues will see you. If it doesn't feel so bad, call and make an appointment, and I'll see you next week. Monday morning, I get back to clinic, and there's an indignant voicemail message from Mr. Amadou. He said, I come Friday, there, so I go home. I thought, ugh, all right. Either he didn't understand my message or he's just being stubborn, which he is also. The next week was a series of missed messages between us. He'd leave me messages saying, Dr. Ofri, I need to see you. It's really important. I leave a message saying, if it's urgent, please come to walk in. If not, please make an appointment. He'd leave me a message saying, Dr. Ofri, I need to see you. It's really important, never acknowledging my messages to him. This went on the whole week. It's now the following Thursday in the morning. It's around, 11:55. I think, okay, I'm just going to grab 10 seconds for lunch before my afternoon patients. And I see Mr. Amadou in the waiting room. He's tall. He's kind of a beanpole, really skinny guy. He's always wearing a tracksuit. This time it's powder blue. And he's waving anxiously. Dr. Ofri, I need to talk to you. It's very important. And I was unprepared for the wave of anger that overcame me. And I thought, I know he's got a bad heart, but he just can't walk in here and expect me to drop everything and see him right now. So, Mr. Amadou, look around the waiting room. It's packed with patients with scheduled appointments. This is pre-COVID, obviously. They're all waiting. And, I can't just drop everything and give you an appointment. I'll make all the other patients late. If it's urgent, we have a walk-in clinic. And he kept saying, it's really important. And I'm weighing that, primary care. I thought, okay, work now or work later. If I put it off till later, it'll be twice as much work. All right, let me just do it now. So I say, okay, Mr. Amadou, just this once, a very short visit. And next time you have to make an appointment like everyone else. I lead him back into out of the waiting room, and he's got this big smile on his face, like he has got the system licked, right? If he just keeps being persistent, I will eventually cave, which of course I always do. And he's got this worked out. And I'm kind of growling under my breath, thinking, God, I can't believe I cave in on this one. And I'm leading him back into my office, and he kind of freezes in the doorway. He's like in mid-step, and it's as though his body can't decide whether to propel it forward into my office or to go backward out back into the hallway. But it's all an illusion as he drops to the floor with a heart-stopping thud. And that's that moment of, oh my gosh, we're now in a different situation. And I drop to my knees. I call a rapid. I try to get a pulse on him. It's 120. I say, Mr. Amadou, can you hear me? Are you okay? And he puts his hand on his chest and says, my heart. And of course, I'm swamped with a horrific wave of guilt. And so I call for oxygen and a stretcher, and I cram my stethoscope under his chest, under his tracksuit, try and listen to his heart. I try to get a pulse ox, but his fingers are frigid and I can't get a reading. And of course, he's laying half in my office. His legs are out in the hallway. He's 6'4" or so. We can't get the stretcher in. We've got to get two people climb over him and carry him out onto the stretcher. It's a complete, clinic rapid response nightmare. Um, we get him onto the stretcher and we start going to the emergency room, which is like a city block away. And the whole way I'm kind of feeling awful about how we got into the situation. Get to the ED, I hand off care to my ER colleagues, and I turn to say goodbye to him, as he's going there, and I have to go back, and I take his hand in mine, and it's absolutely frigid. And I apologize for berating him in the waiting room, for berating him, on the phone, for all of our series of miscommunications. And he's too breathless to speak. He just gives my hand a weak squeeze. And so I walk all the way back to clinic, that long city block in the hospital. And I'm staring at the floor the whole time. And I don't know about your hospital, and maybe it's all hospitals, maybe it's just mine, but the linoleum of hospital floors always looks like it comes pre-flecked with vomit, right? All those brown and beige and gray dots, I think, are there to, cover the camouflage the spills. But I remember focusing on all those dots, looking at every single one, dissecting our week of communications or really miscommunications, feeling terrible that however this happened, he's now in the emergency room, and we couldn't avert this. And, it made me think that we were not just miscommunicating, it's like we were speaking a different language altogether. And, we all know that communication is important, that it's paramount, but I think the public tends to think of doctor-patient communication or any caregiver-patient communication as like bedside manner, right? It's nice if you can get it, sort of an affable bonus that, some kindly doctors possess, typically the ones with bow ties and white coats all buttoned up. It's great if you can get it, but you'll hear, oh, so and so, great doctor, lousy bedside manner. But as I delved into the research for this book and spoke to patients and doctors and nurses and researchers and families, I realized that it's not just an affable bonus. It really is the most powerful tool we have in medicine. And I know that we all know that, but really digging into the data to see it proved was really eye-opening. The Greek philosopher Epictetus was supposed to have said, "We have two ears and one mouth, such that we can listen twice as much as we speak." Now, it's clear that Epictetus was not a physician in 21st century America because we obviously talk way more than we listen. We doctors verbally dominate the conversation at baseline, but even more so if our patients are elderly or obese or African American or poor or pregnant or any group you name, we even more dominate the conversation. And and it's not that, we intend to do that. We have a lot to say. We want to educate our patients. We want to find out the problem. So we just yak, yak, and yak. And everyone on this call probably knows the data that when patients, open their mouth to give their first words, that we doctors cut them off on average of 8 to 10 seconds coming out of the gate. And when I give a version of this lecture to the lay community, they're horrified at that statistic. You doctors are so rude. You don't let us talk. And I try to explain that we're not rude. We're not trying to be rude, but we want to get the answer. The patient comes in and says, "Oh, I've got this pain over here." And we dive right in. When did it start? When did it stop? What makes it better? What makes it worse? Blah, 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 blah. We want to solve the problem. We want to make our patients feel better. But if the patient maybe had a second thing to say, like, "I think I might have had a stroke last week," we'll miss that because we've gone down that shoulder pain pathway. And when I talked earlier today about medical error, one of the most difficult types of error to attack is diagnostic error. Misdiagnosis, delayed diagnosis is very hard because we can't checklist how we think and interview patients. But you can see the germination of diagnostic error right in those first 10 seconds when we dive and cut off our patients and we divert them down the pathway that we want to talk about and never or rarely get back to what they had to talk about. And so I wondered, well, how long would patients actually talk if we didn't cut them off at all. And I polled my colleagues, and they're like, oh, no, never do that. The Puerto Ricans, the Dominicans, the Greeks, the Irish, the Italians, you name it, whatever group, they'll talk on forever. And so I looked in the field and I found one study from Switzerland that did it precisely this experiment. The doctor would say, how can I help you? And then not say a word. And how long did the patients talk? On average, about 92 seconds, right? Not that tsunami we're all fearing, but of course, the Swiss, reserved, precise, diplomatic. Maybe they don't have that gene for loquacious gab that we Americans have. So I thought, okay, I'll do that in my own clinic. So the next morning, I did the same experiment. First patient came in. I said, how can I help you? And I shut up and said on the stopwatch, 30 seconds. But that patient was just here for a job physical, pretty easy. Next patient, weekend warrior, knee pain, back pain, 36 seconds. Not bad. Third patient, middle age, the LDL, the diastolic all going kind of in the wrong direction. That was about 47 seconds. And I thought, they're right. Patients don't talk on forever. But then came the kicker. Josefina Garza, which is not her real name, and nor is Omar Amadou his real name. Um, Miss Garza is a patient from Argentina. She's a teacher, a retired teacher, and I adore Miss Garza. And she has anxiety and depression. She's got irritable bowel syndrome. She's got an elderly mother she's caring for who has some slight dementia and is a very cranky and doesn't sleep well. She's got a good-for-nothing son who won't get a job and move out. She's got an unsympathetic boss who won't give her days off to take her mother to the doctor. So a ton of stresses in her life. She's had a, recent stress test. She's had the $1 million workup, but still she comes in with a million things in her mind. And I thought, oh boy, if I let Ms. Garza talk uninterrupted, I'll hear a rundown of every organ system in her body and every organ system in her mother's body. I'll hear her, her mother's doctor's opinions I'll have to verify or validate. We'll be here forever. But I thought, I said I'd let every patient talk today. I can't, bias the data. So I gird myself for battle and say, okay, Miss Garza, how can I help you? And she opens up and says, everything hurts from my nose to my toes. And we go down the list, and her tongue is burning and her hair's on fire, and she's got swollen elbows, and her stomach is upset and her head is swelling to 10 times its size. On and on we go. Each time she pauses, I say, is there anything else? And there always is. And we just keep going. And, but I say nothing. I just take a few notes as she's speaking, and I just wait. And 27 hours later, we come to the end of all she has to say. But when I peek at the stopwatch, it was 4 minutes and 10 seconds. Now, it felt like 27 hours, but it actually wasn't, which I think is a really instructive thing. I think that most of us, honest enough to admit it, we hate patients like Ms. Garza, right? Because they have a polypositive review systems. They go on forever. And most of their problems are things that we can't solve, right? They relate to socioeconomic issues. They relate to immigration issues and things that we can't solve in an alcoholic husband, a good-for-nothing employer, all these things, bad shoes that we can't help that cause their problems. And so we want to shut these patients up, right, as soon as we can before they give us another 20 things that we cannot solve. But when I finished this list, I looked at it with her, and what struck me is that the list was long, but it was finite. It did not go on forever. And once we had a list, we could actually make a plan. I said, okay, you know what? We've got, whatever, 50 things here. If we do them all today, they'll all be superficial. Let's pick 3 or 4 for today. You pick 2, I pick 2. And we'll get to the rest of the ones, next time we come. And when we finished, she said something that I've read about, but I never actually heard a patient, in fact, say. And she said, just talking about this has made me feel better. And, that's really the name of the game, right? We want to help our patients feel better, especially our patients who have chronic pain syndromes for which we have very few good treatments and for whose pains we know are caused by things beyond standard medical issues. Letting the patient talk can actually have a therapeutic benefit. And the other thing that happened is that usually after her visits, I get a barrage of phone calls and emails and things to follow up. This time it didn't happen. And whether getting it all out lowered her cortisol levels, upped her endorphin levels, I don't know, but she felt better. And then I wasn't bombarded with calls. And then our next visits were actually more efficient. And so when I talk to my students and house staff about being efficient, and Lord knows we have got to be efficient, we have a huge, busy outpatient clinic. I talk to them about the counterintuitive strategy of letting the patient talk uninterrupted for the first minute. A minute of being listened to, full frontal listening, no computers, nothing else, is actually quite a bit. And most patients will get out what they have to say in that first minute. And then I'll say something like, I don't want to miss what you're saying, so I'm going to take notes while you speak. Is that okay? And I pull the computer in. And most patients understand we have to write while we listen to them. And so this is, a way that we can use our communication strategies to both decrease our diagnostic error, to help our patients actually feel better. It's one of the tools that we have in our bag. Um, Back in 1964, which my teenagers called the Dark Ages, there was a great study done about post-op pain, right? Especially with abdominal surgery. As we all know, post-op pain, it's a nightmare. It requires opioids, which have, the side effects we want to avoid: nausea, vomiting, constipation, addiction, respiratory suppression, death. We all want to minimize opiate use. And so in this simple study, they took 200 patients going for abdominal surgery. The night before, the anesthetist walks around, talks to each patient about the procedure, but for half the patients, randomly selected, they added in a 20-minute discussion about post-op pain. And there was no rocket science here. It was just, here's what the pain is like. It's caused by clenching of the abdominal muscles. Here's some exercises to relax the muscles. That doesn't work. Here's the button to call the nurse. And if they come, here's what you'll get, right? Nothing too unusual. And the next day, the surgeons operate not knowing who's in what group. Now, from the perspective of today, I think it seems obvious that the patients who got a little extra education about pain probably did better. But what impressed me was the magnitude of the improvement, that these patients needed 50% fewer opioids. And that's a really powerful clinical outcome. And I think as internists, we can be united in saying that anything that minimizes constipation is a gold medal in our book. But furthermore, those patients were discharged from the hospital 3 days earlier. That is 3 fewer days of falls, infiltrated IVs, nosocomial infections, DVTs, plus the cost of 3 days of hospitalization, all from a 20-minute, very basic conversation about post-op pain. And so and that study really kind of set the field on fire about how the communication skills that we have can actually have meaningful clinical outcomes, not just sort of the touchy-feely, oh, the patients really like it, but it actually makes a difference in their care. And there's one more study I want to just mention, is a study on low back pain, right? We all hate low back pain because we can't do much about it. It comes in all of our patients, but we all want to refer patients for physical therapy. And when I think about physical therapy, the referral, I think about, the exercises the therapist will do with my patients, maybe some massage, maybe that fancy electrical stimulation machine. But I rarely think about it in terms of the communication that the therapist might have with the patient. And this brilliant little study done in Canada, they took almost 300 patients with standard issue back pain and divided them in half. Half was going to get the electrical nerve stimulation machine, and half would get the sham machine. You turn it on, you hook the whole thing up, you don't turn it on. This new machine's really quiet. And what's interesting is if you put the sham machine on, the patients have a 25% reduction in their pain scores. Right off the bat, you do nothing, but the placebo effect of the machine already makes patients feel better. But when you turn the machine on, the pain scores go down by 45%, which is good. The machine actually works, and the machines are really expensive, so it's good to know they work. But then they further subdivided the groups in half, kind of a 2 by 2 design, with the therapists. Half the physical therapists were told to just be silent, and the other half were told to engage the patient, make eye contact, ask about the pain, how it affects their life, be optimistic about the pain getting better, all the things we want for a therapeutic relationship. So now you have a 4 by 4 design. So you now have a group of patients who have a sham machine, but an engaged therapist, right? And those patients had a 55% reduction in pain scores. That is, the engaged therapist was more effective than the machine, which probably costs more than the therapist's salary. And it's really amazing to see. And of course, it's additive. If you got the machine and the engaged therapist, you had a 75% reduction in pain scores. So, and there's a plethora of data to show that the way we speak to patients can have meaningful clinical outcomes, especially in the difficult to treat area of pain. And so we recognize that some of this is placebo effect. And we tend to think of placebo as, oh, this is what we use in research trials, right? That's the standard. But placebos in clinical use, that feels a little, ethically shady. But, we often think about placebo as the pill, but in fact, the placebo is everything around the treatment, how we speak to the patient, how we engage the patient. I'll give you just one more trial of patients with chest tubes, right? Also another very painful experience. And two groups of patients were given the same dose of morphine Q4 hours in the IV. One half got it automatically, and one half had the doctor come in and administer same dose. The ones who had the doctor administered had twice as much pain relief for the same dose of morphine. All the rituals of the person coming in, expressing their care, the pulling up the syringe, all of that doubled the effectiveness of these medications. And so we have to remember that it's not just, a nice, bedside manner, but it's a really important clinical outcome for our patient. And it's really changed how I've practiced because even open label placebo works. Ted Kapchuk, who does all kinds of great placebo studies at Harvard, did one with irritable bowel syndrome, a difficult to treat syndrome. And he said, this is nothing. There is nothing in this pill. But research shows that people on placebo will have a relief of pain. And a third of patients felt better. Is that unethical? I don't think so. If you're the patient, I don't think so at all. I had a patient once say to me, I don't care if it's freaking dill pickle, if it's going to relieve my pain, I want it. So of course, we're not going to give a placebo instead of an antibiotic or an antihypertensive, but to recognize that placebo has a big effect. And I use it a lot now with the lowly multivitamin. Patients are always asking, will I have more energy if I take a multivitamin? I get the question all the time, and I'm sure you do too. And in the past, I would say, that's crazy. Not at all. There's no data to support that. Plus, you're just going to pee it all out anyway. Now, I answer differently. Now I say, a lot of my patients feel more energetic if they take a multivitamin. And that, by the way, is not a lie. That is a true statement. Lots of my patients tell me they feel better. And when I present it that way, a third of my patients come back and say, I feel so much better. Is that unethical? I don't think so. Again, I'm not doing that instead of their chemotherapy or instead of their Plavix, but as one more kind of thing that we have in our armamentarium that can help us with our patients. So if our conversational skills, both listening and speaking, can have such powerful effects, why does it get no respect? Well, partly it's because of how we bill, right? If I take a disease like diabetes, we do this every day, and most of diabetes is talking. It's education about how to take your medications and how to eat and exercise, all of these things. Um, but if I sit and talk to my patient about how to cook brown rice instead of white rice, which I do all the time, I have a dot phrase for Dr. Ofri's brown rice recipe in English and in Spanish, which I can send to you if you want. Um, um, what's Medicare, going to reimburse the hospital? I don't know, $48 on a good day. But if, while I'm talking to my patient about, how to have kale instead of potato chips, I simultaneously thread a tube into one of my patient's orifices, and you can pick any orifice you want, that reimbursement goes up like 20-fold right off the bat. Um, and if while I'm doing that, I run a CT scanner over them, you're talking big bucks. So it's no wonder that, CEOs who are running a hospital or a healthcare organization, they're going to lean toward things that bring in the bucks and pay the bills and keep the lights on. Doctors yammering away about how to cook quinoa, that is not going to pay the rent. So our whole system, is really weighted toward procedures and not toward the conversation, the cognitive side of medicine. And there's, of course, a whole history about why that came to be. Um, I often go to these conferences about, reimagining healthcare, and they're always talking about, how we're going to, the synergism that we can do and how we can restructure healthcare. And I hope that in this whole, kind of push to recalibrate healthcare, that we think about the simple conversation between patients and their caregivers, their nurses, their doctors, their physical therapists, starts to get more front and center. And because medicine today It is chronic illness, right? There are very few things like appendicitis that we can cure with one procedure. Most everything, COPD, depression, obesity, congestive heart failure, these are long conversations with patients over hours, over years. Um, and so we need to look at the conversation between patients and caregivers as a very important technology in treating these illnesses. Um, and we have all these great flashy technologies, which, I love, but most of the technologies that we have, they only do one thing in one way. But yet, the simple conversation between patients and caregivers is, in fact, a very flexible and a highly sophisticated technology. If you think about all the possible diagnoses you can elucidate just in a conversation, even the treatments you can give just in a conversation, the decisions you can make in a conversation, chemotherapy, when to start, if we should do it, dialysis. Um, I had a dialysis conversation with a patient today, starting dialysis, and that is all a conversation. The simple conversation is, in fact, one of our most powerful and flexible technologies, and we need to give it its due and to treat it like any other fancy technology and to reimburse it at rates that commensurate with those technologies and give it the time for that. And so when we restructure, healthcare and we think about, cost effectiveness and efficiency, safety and minimizing medical errors, improving clinical outcomes, and of course, increasing patient satisfaction, the conversation part of healthcare ranks high in all of those. And the good news is that it's pretty cheap, right? It costs much less to do. Um, and it has very few side effects, right? Our conversations do not make our patients hyperkalemic. They don't put them into renal failure, give them outbreaks of rashes, make their hair fall out. We don't make them puke. It doesn't, cause them to lose their sex drive. Though if I think about the conversation around politicians, I can't quite make the same statements, but that is another conversation. And so I really want to, make my case that although we all know the conversation between patients and caregivers is so important, we need to make that case to our administrators, to our health insurers, the people who are paying the bills, that this needs to be, treated like any other technology, any other patient safety intervention. Um, I do want to just end with reading a little bit of the end of Mr. Amadou's story so you know what happened. When I think back to my communication mishap with Omar Amadou, I can see more clearly how and why it was so exasperating. The geometry of our conversation went awry as we pursued divergent dialogues. Although I appreciated the severity of his cardiac disease, I was irritated by the muscularity of his insistence, and I quickly pegged him as a difficult patient. And my labeling of him distorted what I heard. In his persistent demands for my time, I discerned entitlement, and I became resentful and downright angry. Had I stopped for a moment, arguing about appointments with him and phone calls, I might have been able to intuit the animating impulse of his desperation. Those of us whose luck has kept us from facing down death, we can't really appreciate the exquisite vulnerability that serious disease engenders. Raw fear is a motivating force like no other. When I tried to imagine being Mr. Amadou, negotiating an unforgiving medical system, all with a heart that's flagging before its time was up, I can begin to understand his approach. Why wouldn't he insist on what he felt was necessary? Why wouldn't he refuse to take no for an answer? But I wasn't able to fully comprehend that until his body crumpled in my office and I felt the life wicking away from him. After his faulty pacemaker was replaced and the excess fluid was drained from his lungs, Mr. Amadou came for a post-discharge appointment. It was an intolerable relief to see him, to see his lanky frame and his trusty tracksuit filling my doorway. And when I shook his hand, the hand that had been so frigid last time I touched it, I now basked in its warmth. I had no illusions, of course, and neither did he. The recent tune-up did not impart any fairy dust of additional cardiac reserve. Mr. Amadou would not be doing the 500-meter dash down Lexington Avenue any time soon. But we dodged the bullet, this time at least, and we both exhaled cautious sighs of relief. Mr. Amadou's first question, of course, is when our next appointment would be. Normally, This would irritate me, but now his voice unfolded almost like a benediction. I couldn't promise that we'd never have miscommunications in the future, or that I or he wouldn't get aggravated when things didn't work out the way we wanted to. But I could promise that I would pay more attention to how I spoke and how I listened. And I want to close with a quote from my favorite poet, and it's particularly resonant, I think, for this audience. Dr. John Stone, as many of you know, to me, he's the patron saint of Emory, and he delivered, I think, the most beautiful commencement address to a graduating class some years ago. It's a poem called Gaudeamus Igitur, Latin for Therefore Let Us Rejoice. It's a 4-page poem. You can find it easily. Email me and I'll send it to you. Um, and he used this poem to help students navigate the moving on, the commencing forward from our training times to our stepping out into becoming doctors and becoming clinicians. And I try to read the poem with my students whenever we're at a commencing point, finishing a rotation, about to graduate, finishing residency. It's a long poem, but it's worth every moment. And I just want to give you one line. Dr. Stone wrote, "For you will learn to see most acutely out of the corner of your eye, to hear best with your inner ear." And I'll say that one more time so you can take it home with you. For you will learn to see most acutely out of the corner of your eye, to hear best with your inner ear, and a more astute lesson in communication I could hardly imagine. Thank you so much.
Thank you so much, Danielle. I hope that you're hearing all of the claps that are occurring in individual dining rooms, studies, wherever people happen to be. I've been getting emails, we're seeing things on the chat about how much they're enjoying this talk. So I really appreciate it. Let me start while people are kind of composing their own thoughts about what they'd like to ask you with a question. So as you know, Dr. Branch is a pioneer in primary care education and doctor-patient communication. Based on your own experience as a clinician and educator, what would you say are the key ingredients to robust primary care education that promotes humanism?
So often in medical education, we want to teach something, be it multiculturalism, racial sensitivities, different things like that, communication. We come up with a core competency, and we have a 1 to 7 Likert scale for judging our students, and we have a PowerPoint presentation and some kind of module to watch. And, I think these are things that only can be done in person. And I think the way that we teach humanism, as in communication, as in cultural sensitivity, is at the bedside. And I think back to my great teachers, and the most valuable lessons I learned in humanism were at the bedside. And it wasn't that these were all, folks who did the Peace Corps and backpacked in Nepal and had all this great awareness of the world. Many of them were very, buttoned up white coats, older white men. But yet, they exuded a clinical curiosity about wanting to know who the patient was. And that demonstration was one of the most powerful lessons. And I can only see that at the bedside. And I think for all the things we want to model, how to talk about end of life care, how to break a difficult diagnosis, how to handle a medical error with a patient, these are hard things to do, and we can't learn them in a PowerPoint. But if we witness a good mentor, an experienced clinician at the bedside in real time, demonstrating how we do it, warts and all, I think that that is the best way. And it's a very labor intensive way to teach. It's not as convenient as, handing out the PowerPoint to all 200 students, but that is the way, we do. And we talked earlier in Grand Rounds today, the difference between being smart and being wise. Being smart, you can get that from your PowerPoint. You can get that from up to date. You can get that from studying. But being wise is experiencing in the moment, of seeing how we help patients negotiate difficult decisions, how we handle our own difficulties, how we handle the embarrassment of talking about an error that we've made, or explaining when we don't know something in front of a patient. These are things we do in real time. So I would suggest the best way to teach medical humanism is together at the bedside in real time.
you for that. So one question that came in, I agree with your comment on how procedure-based therapies make more money in healthcare. However, much of the examples you state on communication could eliminate waste and save money, like your length of stay example. How best can this data be collected and used to convince administrators to fund?
Ah, that is the question, right? It's very hard to study because, things are often not fungible because the money saved by better communication is often in a different pot. So, for example, if we prevent unnecessary dialysis in a patient who is maybe end stage and shouldn't have that, that conversation may take an hour, right? And may run us over time and run up costs there. Saving dialysis resources comes out of another place. So those folks aren't going to realize that the money was saved because a primary care doctor spent the time explaining the ramifications of dialysis. So it is very hard to study. I mean, there are some people out there working on that and trying to model, what it would be, but it is very it is very hard to do. I think we can try to find, small examples, in our own clinic, for example, how frequently, if we take the quote frequent flyer patients, how often they come back, even just for visits, and if we can demonstrate that having more time in a session can actually decrease the number of visits and certainly, emergency room visits, which is a big, utilizer of resources. It is very hard. But I think we can certainly explain anecdotally. I think it's quite obvious that we can do that. And we have to convince our administrators to look beyond the direct pots of money and see the distinction between, for example, helping a patient take medications correctly, right? That will save emergency room visits. Helping patients use their inhalers correctly for asthma, that's an easy one to show will decrease ER visits. So if we can find small examples like that, we can try to show it. But I absolutely admit it is not easy to do because it's a little, it's not easily fungible. But I think some important things can't be measured. It doesn't make them any less important.
I totally agree. Open Note is upon us in a few weeks, and so we're all thinking even more closely about communicating in our notes in ways that are intelligible and respectful, useful to our colleagues, but not offensive to our patients. What are your thoughts about how this will change the doctor-patient communication, and any thoughts about the pitfalls and the possibilities?
That is, it's really trying to thread the needle of trying to, you're addressing different audiences for different uses. And so one thing is we have lots and lots of shorthand that we use for our other colleagues. And, to say ESRD makes sense to my colleague, but to a patient it might not. And that's going to be a tough one. I think though what might be salutary is that maybe we'll simplify our notes. I mean, right now in our and I hate to point the finger at the specialists out there, but most of the specialty notes are these enormous, huge bundles of labs and copied forward things and useless electronic fluff. And I just scroll to the bottom for the two-liner that actually has the nugget. And maybe we can finally say goodbye to those bloated, essentially useless notes and try to be more concise, but put the relevant bits of information in there. So I think it will force us to think more carefully. I think it'll help us avoid some derogatory terms we sometimes use because that wouldn't be kosher, which we shouldn't be using anyway. And maybe to get more to the point, but we'll have to be careful without getting too jargony and keep things very simple. And the truth is, with the electronic medical record, I think that in our notes, simplicity is actually better. The other thing it might force us to do, and I think this may help us again in the area of medical error, is that, in terms of diagnostic error, that we often and most charts do not contain a differential diagnosis. And maybe when we, if we don't want to commit too heavily to a patient, we think we have X, we can also be more careful and write, well, other possibilities include, here's the range of things that could conclude that may make more sense for the patient and also get our thinking process on the page. I don't have the easy answers on that, but I think it's going to be a communal effort. I think one thing we might want to point out to our administrators is that we may need more time. To start writing these sorts of notes takes a recalibration of our thinking, and that if we don't allot a few extra minutes per session, those notes might be really bungled. Good luck. That's all I can say.
to all of us. Here's a question from the chat. The therapeutic use of self, which includes listening carefully and completely, as you have so clearly documented with evidence, what is the strategy for making it clear that this is what general medicine physicians can and should be doing and paid to do? We do
Well,
not need
again,
additional practitioners as much as we need the time to do what we know needs to be done.
yeah, and again, I think it's always in the seeing it happen. So one good example I do, in terms of medical education is very often in the waiting room, again, pre-COVID, when the waiting rooms were packed and patients were, being forced to wait, and a lot of, tempers would go up. There'd be, the angry patient in the waiting room. And typically the response was get the administrator, get hospital police. And I always say, no, no, I want to go do this and let me bring my students with me. And I think to take the students and the house staff into a difficult situation and, have them see how do we handle a patient who's upset or angry? How do we undo this? And then afterward to talk about how you used yourself in that. How do you help a patient, come down, from the heights of anxiety and anger? And the same thing when you do a difficult diagnosis. You know, negotiating the switch from, a treatment-oriented, curative-oriented treatment versus a palliative, that's a very difficult conversation. And when I've done that with a team, what I want to do afterward is then analyze what have we done? What have I done? What parts of me did I use as opposed to just my checklist of things to do? How did I open up, share my vulnerability? What strategies did I use? And so I think we can be explicit. Again, it requires, teaching in the moment in real life and not kind of a checklist of things to do. I hope that answered the question.
Thanks. A question from Dr. Branch. How much have you benefited in terms of feeling rewarded by your close relationships with your patients?
Ah, gosh, TNTC, too numerous to count. Um, really, really. So as I mentioned today, I had a patient who I had to have the conversation about, we're starting dialysis, on Thursday. And that was a very hard conversation. And I needed my patient to buy into that. And he could because we've had now years of these conversations about various and sundry health things. And it is so gratifying to have a patient be willing to trust you with this difficult decision. Um, and I can see so easily why a patient wouldn't trust a doctor, right? We come in with all these things saying we got to do this, got to do that, and they don't necessarily see what our agenda is. But when you get to the point where a patient will trust you with this life-changing decision, and I wouldn't say it makes me happy because obviously this is a sad moment for this patient, but it makes me feel gratified that we're able to transition his care in the least difficult manner possible. And the same thing with, helping our patients through the end of life. Those aren't happy moments, but they are gratifying that if you can help your patient get through that moment, it makes you feel like, I have chosen the right job, and despite all the headaches of the day, of which there are dozens and dozens, when score one for a patient's care being 3 degrees better than what it was before, then it just makes it all worthwhile. And then, of course, the patients make you feel like you've done something worthwhile. You're making a difference in the world. And, how many people in the working world get to say that? A lot of people do jobs that they feel don't make a difference. And again, I think a lot of us during the COVID pandemic felt that many people were stuck at home thinking, what's the point of my job? We are so fortunate. We get to be in a place where we get to make people feel better or able to tolerate their pain better. Um, that's just a gift, and we are the luckiest people alive.
How have you felt that telemedicine has changed doctor-patient communication?
Well, it's interesting. I was initially dreading and I hated it, dialing one number after another. But I started to find some things that actually made it work better. Um, and not that I want that over in-person medicine, but I found that, patients being at home was a more relaxed place. And I found patients were more comfortable. They're not in that tense waiting room and these sort of emotions and anxieties that come up with that. Also, they have their medicines there. Oh, here's the medicine. Or they could show me the picture if it's a video visit. Um, I also have the benefit of family members being present and could be part of the conversation in a way that was much more natural, especially if they couldn't come in person. It is a little distant, compared to the in person, but it also takes on a very chatty conversational tone, which is a little different than being in the office because the patient is now not seeing you at the computer. They're hearing you and they don't feel that computer being in the way. So there is a way that we can take advantage of that. I think also, at least for me, it has lowered my stress levels. Now that my patients aren't waiting in the waiting room and I can call them 5 minutes early, 5 minutes late, it's not going to make so much of a difference. It's taken some of my stress off that, oh, I can take 5 extra minutes to look something up or to extend a conversation. Hey, I could even call the patient the day before if they're available. And then I'll have more time I know a patient will need more time, so I can leave more time for that patient. So having a little bit of flexibility and agency on my end has actually made it easier. So I think it's different. I'm not going to say better or worse, it's different. And I think it behooves us to focus on what are the things that make it better. It's easier for the patients, more convenient, saves them the long drive, the long trip. And so it's just one other, way we have. And what I foresee in the future is that we have a mix. We have maybe in-person visit once or twice a year, and then we can fill it in with a telephone visit. I mean, listen, before, telephone visits, if we called a patient, you could do all the medical care you want. Your institution was not going to get reimbursed for all that care because it was a telephone. But now it's a telephone visit. All of a sudden, oh, now that's a value. Now we can reimburse that. And of course, reimbursing it gives it value, which means our institutions give us time to do it. So I think that's a salutary a change as well.
Thank you. When you started your career in medicine, it was predominantly male profession, and now there are more and more women in the field with perhaps different communication styles. I'd love to hear your thoughts about how you see women or just a new constellation of medicine changing how we teach and teach our students and provide care.
It's interesting. I don't know so much if it's a male female thing, but more of a generational thing. And I think in generations past, medicine was seen as a career for, prestige. It was a career seen for a good salary. And I think many people went into medicine for those reasons or because of family pressures. And I think that's changed now. I mean, nobody goes into medicine, for a salary. It's much easier ways to make money. And so those folks have long since decamped to Wall Street. And I think who comes into medicine now, who goes into nursing now, are people who really desperately want to do this. And I think that is the real change. And so having this drive of being there because you really, truly want to help people and make their lives easier has has been a real improvement. I think communication skills, it's interesting because we now have a generation that communicates maybe is less accustomed to talking in person or even talking on the phone, thinks in shorter bites. And I think we have to help, some of our students, think in paragraph form or think in page form, the way some of the older physicians do. I think overall it's been a very positive trend. Who is going into medicine healthcare now are people who are in it for the right reasons. I think our job is not to stamp that out over the course of their training, right? I think what happens is that they come in with all the right impulses and then we just, flatten that out. And so we have to, as educators, safeguard and preserve that so when they come out the other end, they still have their intrinsic sense of justice, of doing the right thing, of spending the time with patients, and that we preserve that for the benefit of the patients.
Another big change that's occurred in internal medicine and in pediatrics is the general provider, the primary care doctor, is often not the person who's caring for the patient in the hospital. So inpatient and outpatient medicine has kind of become separated. How do you see that impacting the care of patients today?
Well, on the one hand, I think it has to be. I mean, I've tried in various job settings I've been in to do both, and it is a nightmare. I mean, it's not possible. It's just not, and it's not safe for patients. There's just no way you can have a full outpatient load of patients and take care of your inpatients. Just not. So I think it's in some ways safer. Of course, the downside is this fragmentation. So what I do now as the outpatient doctor, and in some ways it relieves me of the stress of the day-to-day decisions of checking the potassium every day and adjusting the weight-based dosing of the antibiotic. I can leave that to someone else, but I get to sort of come in and be the communication contact with the patient. I call them on their cell phone. to see how they're doing. And it allows me to get the best parts of doctor-patient communication without having to do the drudgery work. And then, of course, but the key thing is that we look at the inpatient and outpatient doctors as really a team. And at some moments, one doctor is doing more of the work, and another doctor maybe is doing a little bit less, and then it shifts on the other way. And that, we see it as sort of a partnership. I think it's beneficial for patients medically, but we have to work to make sure it's beneficial in terms of communication and doctor-patient relationship. It can be done, but it takes some extra attention.
Great. Thank you so much for that. I think we are about at our time when we were going to turn it over to Dr. Branch to say a few words. I want to thank you very much for this fascinating conversation and for your wonderful talk. Thank you, everybody.
There you are.
Great. Dr. Branch, there you are.
Yes. Can you hear me?
Yep.
I'm told I have 5 minutes to say a few words, and I have a lot of gratitude to express. I could use the whole 5 minutes just saying how grateful I am. And I just feel so good about this. It was such a wonderful occasion for me. I appreciate so much Hugh's being here, Shelley Ann, who has been remarkable in organizing this. I see my own mentor, Marshall Wolf, up there making a comment. And I was going to say earlier today, talking about how you could deal with your mistakes and issues by talking to a mentor. I did that very often when Marshall and I were working together. I'm also grateful to Ted and all the people I've worked with in primary care, both in Boston and here at Emory and Grady. I feel as though I've been in medicine for 54 years. And I feel as though I've been a part of something really wonderful. And especially here at Grady, I've been part of something. And I've seen how the people that work here have done such marvelous things. If there's anything that I feel proud of, it's what's been done by the folks that came here to work and that had developed into such amazing people. So being a part of that, and I have to say that I feel like for a long time I was working on that. And since then, Ted has done a marvelous job of continuing with what we were doing at Grady to really make this a division of people that love each other, support each other, and at the same time can make huge advances in terms of the quality of the care that we're able to give. So having said all that, I would also want to say this talk, of course, brings back enormous numbers of memories and stories to me. I was at one time one of the most strictly materialistic, scientific oriented people that you could find. And it was only when I discovered the world of patient-doctor communication and the change that it made in my practice, in my own experience, and in the experience of my patients, as I observed how much a relationship with a patient that the patient appreciated and felt was a genuine relationship had a therapeutic benefit. I observed that. I felt immensely rewarded by that. And I felt immensely rewarded by the patient's feelings toward me, which changed a lot once I started to really connect with them. So to me, this is a long story that started way back in the 70s and has continued on and on in the themes that Danielle was bringing up. are the same themes we've been working on for so many years. And it's just great to see it come to fruition and a new generation of people and someone talented like Danielle taking up these same issues and taking them forward even beyond where we were before. So I'm going to end with that and just say this has been a marvelous evening for me. And I can't say how much gratitude I have for everyone, for Danielle and everyone else who participated, all the folks who participated in the chats and everything, whose names I recognize. So thank you so much.
Thank you.
And I'll just finish this off as well by saying thank you, Dr. Branch. There's lots of messages in the chat about people talking about your impact, and I know you've had an impact on my career. Thank you, Dr. Ofri. I'm so grateful that you were able to help us honor Dr. Branch by being our inaugural speaker. And also wanted to thank Dr. Evans and Dr. Johnson and the entire committee that worked with me to help this event be so special. We wanted it to be in person, but it was still amazing as a virtual event. So just want to thank you all. I'm just going to share my screen again real quickly to finish up a couple last few things that I wanted to mention to everybody. So first off, that there is a virtual door prize giveaway. So we're going to pick 30 people from those of you who attended today and provided your mailing address to us, and you'll get a copy of Dr. Ofri's book, and that will be mailed to you. And we have one more special event that Dr. Ofri will be participating in tomorrow with our own Nate Spell, who is in our Division of General Internal Medicine, and he will be interviewing her for the Decatur Book Festival tomorrow about her book, When We Do Harm. So I hope you will join us, and definitely let family and friends know, because this is meant for a wide audience. So with that, we will wrap it up, and I thank you all so much for joining us tonight.
Thanks. Good night.
Good night.
Good night.